So, you know, in terms of us, we feel like we have some good things to build off in Wisconsin. We, for instance, aren't all that worried about the Medicaid expansion. We think our Medicaid enrollment will lose some, will gain some. It'll be about net neutral. But at the same time, you know, as I said, we think that there's a number of different elements of what we've done in the past that we can really, in fact, build upon. We got a slide 32. Oh, okay, on that. One more? That'll be an angle impact. Yeah. Okay. So just on page, I'll go to slide 33 because I think it's important just to mention the guiding principles. As we see the exchange, we've made a lot of strides trying to keep things simple in the Medicaid program. The exchange creates opportunities but also challenges in terms of maintaining that philosophy. Our view is to really try to create a single door to healthcare. Now that sometimes gets actually creates some different views. People start thinking only single payer, and so we're actually modifying our language. But it's really to sort of think about this, that you can come in regardless of whether you're at 135% of federal poverty or at 98% of federal poverty, at 500% of federal poverty. You go to a single website, you go to a single 1-800 number to gain access to healthcare. To us, there's a huge value in that proposition. We're going to have families, Arkansas is going to have families where the parents are going to be eligible for tax credits through the exchange and the kids are going to be eligible for CHIP. So how do you treat those families? By sending the parents to one door and the kids to another is not, in our view, the way to do it. We learned anything. I think states that have integrated their CHIP programs with Medicaid to the greatest degree possible and made it as simple as possible, and I think we learned a lot of lessons post-early CHIP implementation, was you want to keep that integrated. We need to learn from those lessons and move forward a similar approach. Second is transformation. We need to make sure that we are, in fact, getting greater value out of our system, and I think that's, at least from our perspective, really where the money is going to where the money is, and that's where the rubber hits the road in terms of healthcare reform. Also, build off regional strengths. I think this is the other thing, and each state's a little bit different in terms of how health insurance is provided. We've got a lot of regional integrated delivery systems. We don't want to push those people out by running some statewide procurement that says the only way you participate in the state of Wisconsin exchange, you have to offer health insurance to every part of the state. We think that would be completely counterproductive to our other efforts, and so we want to make that a focus. Customer service and keep it simple. This is a key thing, and I think, as I said, there's opportunities here and there's challenges. As you look across the bill, it's a lot of pages, and there's a lot of work that needs to be done in terms of implementing a new definition of income, how's that integrate with Medicaid, how you deal with existing populations, you know, how do you deal with taking these, make sure these tax credits are going to the right people, going to the right insurance company. There's a lot of complexity there, but our goal is to try to keep as much of that complexity behind the veil and to try to make it so that individuals who are coming to the exchange are utilizing as simple of a front door as possible. I think there's lots of lessons to be learned from existing experiences. One of our goals is to try to ask as few questions as we possibly can to individuals to tell them which insurance options are available to them, whether that's Medicaid, the exchange, or whatever. We want to auto-populate from as many sources as we possibly can and share as much data as is humanly possible, because the more data that's shared, the more auto-populating, the fewer bits of information I have to give or enter into a website. I think we're all going to be better off. That'll enhance the customer experience and will make the exchange a more attractive place to go. And so I think there's just a lot of fundamental lessons that we've all learned from our experiences with CHIP and implementation integration there that we can utilize. And then finally, I just want to show this, and mainly just to give you a sense. I get a different reaction from this. Some people think it's simple, and some people think it's like really complex. And I guess it depends on your perspective and what you're used to. But this is kind of how we see the exchange functioning in our state, and you know, happy to answer any further questions about it. But we really see it as sort of a board administered by a separate authority that contracts with the Department of Health Services. We're fortunate we have a very modern Medicaid eligibility system and management information system for Medicaid that we want to build off of, which I think positions us well. We've invested a lot in those systems. Not all states are in that situation at all, but we do think it has the capacity to do all the things the exchange has to do, which part of our challenge, and I think also part of our opportunity, is that no one has ever done this before. We all point to Massachusetts, but the Massachusetts Exchange is not really the full-fledged exchange envisioned under the bill. And so that could be a little scary, but I think it also creates some opportunities for us as we move forward to really think long and hard about what this is going to look like in each of our states. And so finally, we do feel that, and all states boast about where they think they're leading the way, and we think we're leading the way a lot in healthcare reform, although, as I say, there's plenty more for us to learn from some other states. Governor Doyle really has made, it's funny, you get elected to office maybe sometimes thinking one thing, and where you end up and leaving, what your legacy is Governor Doyle leaves office at the end of this year. I think most people agree that his strength of the biggest part of his legacy will in fact be healthcare. Even though when he first ran for office, he ran with a passion for improving public education, confluence of events, things that happened. While we made some gains in education, I think some of his biggest gains have been in healthcare, and he's been willing to invest the political chips necessary to get that done, and sometimes facing very strong resistance from the legislature. And then finally is that, our belief in continuous improvement and our belief that, we want to continually be looking at ways to not only expand access, simplify our programs, manage costs, and then also if we look forward to the exchange, to think about how we can leverage our past experiences to make that exchange as transformative a force as we hope it to be. So with that, I'm happy to answer any questions, and once again, thanks to folks who invited me to be here. It's a pleasure.
We only have time for one or two questions, because we want to make sure that you make your plane, but I know that folks here, such great information sharing. There are questions here we can probably address them.
So, it can all be done online?
Pretty much, yep.
How do you verify income and have signatures?
We do an online electronic signature. We also have a telephonic signature option now for those who aren't comfortable applying online. If you call in and apply, we do the telephonic signature. So we actually record your voice and save that. In terms of verification, we check with various sources, and if we can't, and I think that's the key thing, is that we should always strive to check existing trusted sources, and so we check sources through our Department of Workforce Development, other sources to try to confirm income. We also have a large database for employer-sponsored insurance. We have 37,000 employers who filled out surveys telling us who of their workers have access to employer-sponsored insurance, because we have crowd provisions in our CHIP program, much like other states do. And so we used to require somebody to fill out a form and send it in with a signature from their employer, and that was a big problem. And so we eliminated that, and we've now worked with employers to build a database. So to the extent possible, we are always striving, and we do a lot of that today, is checking with existing trusted sources.
I know you're mainly focused on the eligibility, but I was just wondering, as you had the numbers of the increase in enrollment, how did y'all address the primary care physician issue? As you've heard, there's a problem with that here that we have, and how did y'all manage that when you were looking at this?
What's interesting is that we really haven't had, I was saying this earlier, we really, despite adding since February 2008, almost 300,000 people to our program, we really have not had a big problem in terms of access. Part of that is that a portion of that population used to have insurance, but they lost it when they lost their job, and so they came to our program looking for help. So they had established medical relationships, so it wasn't really just a pure increase in capacity or increase in demand, it was just the payer shift. So providers aren't enthused about that, but they didn't start going around turning away their patients because their payer changed. I think that we're somewhat fortunate in the sense that we tend to have a large number of providers, particularly in some of our urban centers, but we've also seen some growth, positive growth in our federally qualified health centers and tribal clinics in certain parts of the state, who, because of cost-based reimbursement, have in fact been able to expand capacity and sort of take up some of the load. I think that it's testament, at least in our state, that functioning in an environment where it's almost near universal coverage, that you can function. That said, it's not going to be the case in all states. And I do think that this is another opportunity for us, and people joke that some people are glass half full, some people are half empty. I'm like, the glass is entirely full, so I'm overly positive in most cases. But I do think it's an opportunity between now and 1114 to have the kind of conversation that's happening today about how do we provide services to this population. We can bury the heads in the sand and say, well, it's just too big of a problem, or we can start looking at some of these thorny issues around scope of practice, how do we recruit new physicians, how do we utilize other types of care, whether that's virtual type services. There's more and more of those kinds of things, telephonic. I think there's resources out there that if you think about it differently, I think there's some opportunities, but a lot of work to be done.
But you did notice that y'all do cover for like mobile, for the physicians that will.
Yeah, although to be honest, if it's a certified provider, they can provide services. They just bill to their ID number if it's a mobile environment or not. I think you have to be open to multiple types of environments in which services are provided, and I think providers are also fairly creative in terms of finding ways to efficiently meet the needs of populations. Yep.
Jason, I was just going to tell you, you will be able to change your chart on Access Wisconsin. Arkansas did use.
Oh, you really? My chart's wrong. Good. 13.
Well, I'm very cognizant that I want you to get